I discussed nephritic syndrome. So those who have attended the session of nephritic syndrome would find this one quite related and continuous process of the same. So we may start now. Okay. Now here there is a case scenario. A 44-year-old man complains of swelling of legs and puffiness around his eyes. His abdomen becomes protuberant and he feels shortness of breath. There is generalized edema and ascites. The labs show total serum protein of 5.2 grams, that is within range, and albumin is 1.9 grams. So albumin is low. In the bracket, we have normal ranges. Serum cholesterol is 530 milligram per deciliter. There are 5 grams of protein in 24-hour urine collection. The urinary sediment contains many hyaline casts but no RBCs or WBCs. Renal biopsy immunofluorescence image is shown in the inlet. Here you can see the immunofluorescence. For those who have attended the previous session, you may recall that in the scenario, we have a middle-aged man and the swelling of legs and puffiness around his eyes basically depict edema. So whenever there is loss of protein from the body, we have reduction in the colloid osmotic pressure, and that causes oozing of fluid into the interstitial spaces and fluid compartments. So result is generalized edema and this puffiness around his eyes. So there are certain areas in the body, of course, which develop edema early. So eyes are those areas, the soft tissue around the eyes basically. Now his abdomen becomes protuberant and he feels shortness of breath. That could be because of ascites, number one, protuberance of abdomen, and secondly, the shortness of breath would be because of pulmonary edema. There is generalized edema and ascites. They have written in the scenario that there is generalized edema and ascites. The total serum protein is within the normal range, but the albumin is low. That is, it is 1.9 grams per deciliter instead of 3.5 to 5.5 grams. So it means there is selective proteinuria. In the conditions we'll be discussing, there could be non-selective proteinuria as well as selective proteinuria. Proteinuria in the initial stages remains selective, but later on it may be non-selective. So here, this could be an early stage of the disease in which we have selective albuminemia. Albuminemia means reduction in the serum albumin, and there is albuminuria. So there is loss of albumin. Serum cholesterol is also raised. This serum cholesterol is raised because of number one, loss of proteins from the body, a reduction in the serum protein levels, and there is secondary excessive production of proteins by the liver. And those proteins which are produced in excess by the liver, it includes lipoproteins as well. So there is a rise in serum cholesterol and lipoproteins. So that's why there is a rise in serum cholesterol of 530 milligram per deciliter in this scenario. Now there is a loss of 24-hour urine collection shows a total protein loss of 5 grams within 24 hours. You may recall the definition which we have discussed previously. By definition, for nephrotic syndrome, the protein loss within 24 hours must be equal to or greater than 3.5 grams per day. This is the main defining feature, one of the main defining features of nephrotic syndrome. If usually in nephritic syndrome, we have less protein loss within 24 hours. So you need to remember the definition of nephrotic syndrome. The urinary sediment contains many hyaline casts but no RBCs or WBCs. So hyaline proteins are lost within the urine and they take up the shape of the renal tubules and nephrons. So they appear in the urine in the form of cast, cigar-like broken pieces. But there was no RBC or WBC, so there are no chances of infection or there are no chances of red blood cells or nephritic syndrome, because we encounter red blood cells usually in the nephritic syndrome. Now the renal biopsy immunofluorescence image is shown in the inlet. I basically shown you previously two types of images. in which one we have ribbon-like immunofluorescence of antigen antibody complexes on immunofluorescence microscopy, which we routinely employ on all renal biopsies. So immunofluorescence, routine staining, spatial staining, and electron microscopy all are done over each of renal biopsies in the centers which have proper facilities for histopathology. Now, there were two images. This one is definitely not the ribbon-like, but it's more of a granular-like pattern. Granular pattern means that the antigen antibodies are not singularly confined to the glomerular basement membrane, but they can be subepithelial, subendothelial, or they can be even mesangial. So here we have a granular sort of pattern of immunofluorescence because of deposition of antigen antibody complexes uh, in this pattern. So this pattern is typical of this condition. Okay. So this is you can see this is one scenario, but there is a lot to discuss in this scenario. We may discuss it for more for 10 or 15 more minutes. So it's a very comprehensive sort of scenario. Now, previously I told you there are a number of primary glomerulopathies. Glomerulopathies means pathologies confined to the glomeruli, the nephron, which may result in these sort of clinical pictures. They include acute proliferative glomerulonephritis, which we discussed in detail in the previous section, causing nephritic syndrome. Then we have rapidly progressive crescentic glomerulonephritis that we also discussed in the previous session. Then we have membranous glomerulopathy, minimal change disease, focal segmental glomerulosclerosis, membranoproliferative glomerulosclerosis, IgA nephropathy, and chronic glomerulonephritis. Today we'll be discussing in the context of nephrotic syndrome the third one, the membranous, then the subsequent minimal change disease, focal segmental, and membranoproliferative glomerulonephritis with a touch of IgA nephropathy. These all may result in nephrotic syndrome, both in children and in adults. Whereas the previous two ones, acute proliferative glomerulonephritis and rapidly progressive glomerulonephritis, we discussed in detail in the session of nephritic syndrome. So these were the primary glomerulopathy. Then there are certain systemic disorders we all know which involve renal glomeruli, systemic lupus erythematosus, diabetes mellitus, amyloidosis, Pasteur syndrome, so on and so forth. So they may all involve renal glomeruli and they may result in nephritic syndrome or nephrotic syndrome. Then we have hereditary disorders such as Alport syndrome, thin basement membrane disease, and Fabry's disease. So this is a classification you need to remember while considering primary and secondary glomerular diseases. Now, this is the main chart that we discussed in the context of various clinical scenarios which may present because of pathologies in the glomeruli. So glomerular pathologies basically manifest clinically in the form of either of these syndromes. Previously, we discussed nephritic syndrome. It was characterized by hematuria, azotemia, proteinuria, oliguria, edema, and hypertension. Then we also discussed this crescentic glomerulonephritis, that is rapidly progressive glomerulonephritis. And today we'll be focusing more on nephrotic syndrome because today's this session belongs to nephrotic syndrome. So here you can see this is the definition of nephrotic syndrome. By definition, the protein loss within 24 hours would be more than 3.5 grams per day proteinuria. Then we have hypoalbuminemia that you have seen in the scenario. Then we have hyperlipidemia and lipiduria, which again you saw in the previous scenario. So by definition, nephrotic syndrome is characterized by protein loss of 3.5 grams per day, hypoalbuminemia, hyperlipidemia, and hyperlipiduria. If someone is asked in the professional examination the definition of nephrotic syndrome, if he or she doesn't give the correct definition, it means the examiner assumes that this person knows nothing about the renal system. He may switch over to endocrinology or nervous system, for instance, because this definition is so imperative and so important for you to remember. And in definition, we do not make any changes. We, even professors, take it as such. So you need to remember this definition. All these components were present in the scenario. So here you can see, okay, what what is the proportion of various glomerular disorders which result in nephrotic syndrome in children or in adults. So, sorry, here you can see, तारिक वीडियो नहीं आ रही. Here you can see that the main proportion of nephrotic syndrome in adults is caused by basically focal segmental glomerulosclerosis. So in adults, it is the focal segmental glomerulosclerosis as a glomerular pathology which leads the causes of nephrotic syndrome. The next in line is the membranous glomerulopathy, then minimal change disease and membranoproliferative disorder. While on the contrary, in children, the overwhelming majority, 65% of nephrotic syndrome in children is because of minimal change disease. Okay. Then we have focal segmental membranoproliferative or glomerulus membranopathy. So there is a difference in proportion of various glomerulopathies which may result in nephrotic syndrome in children as well as in adults. So you need to remember this fact while attempting the MCQs and BCQs. So this again is the diagram which we discussed previously. Just to recall, this is the basic topographic structure of a nephron. Here you can see these are the capillaries, and capillaries are lined by endothelial cells. On the outer side, we have visceral epithelial cells. These are the visceral and these are the parietal epithelials. So visceral epithelial cells are there, and in between the endothelial cells and the visceral cell is the capillary basement membrane. This is the capillary basement membrane. Okay. These are the fenestrations within the endothelial lining. Then we have mesangial cells. These are the mesangial cells which are present in the interstitium of the nephron. Then between the visceral epithelial cell and the parietal epithelial cells, we have the urinary space, which is referred to as the Bowman's space. From here, the ultrafiltrate of plasma enters, crosses the endothelial lining, then the basement membrane, then the visceral epithelial cells, and it comes in the Bowman's space, and from here it is collected in renal tubules. So this is how the nephron functions and the urine is formed. Now this diagram is basically showing various type of immunoglobulin depositions. Here you can see the deposition of antigen antibody complexes is subepithelial within the substance of the basement membrane and subendothelial. So this would give a definite pattern, which is a granular sort of pattern on immunofluorescence microscopy. When they are tagged with immunofluorescent dyes and see under the immunofluorescence microscope, they would give a granular pattern. Okay. Similarly, here we have fixed antibodies, antigens which are there in the glomerular basement membrane, and antibodies come from the serum and attach to those antigens. So the antigen antibody complexes are basically formed within the substance of the glomerular basement membrane. They would give a linear pattern on immunofluorescence. Then we have this another category, which is the subepithelial deposition. This is another type of. So here we will confine to this the granular pattern and the linear pattern. So this is the granular pattern on immunofluorescence. Okay. Granular pattern characteristic of circulatory in situ immune complex form. Circulatory antigen antibodies complexes can deposit at these sites within the glomerule, that is the subepithelial, basement membrane, and subendothelial. They give a granular pattern. And here we have anti-GBM disease, anti-glomerular basement membrane disease, in which we have linear ribbon-like deposition of antigen antibody complexes. Okay, so there is a difference between the interpretation of these two. So in the scenario we discussed, case 1, we had granular pattern of immunofluorescence. That granular pattern of immunofluorescence was because of subepithelial deposition of antigen antibody complexes, which happens to occur in a special category of glomerulonephritis, which is referred to as membranous glomerulonephritis. So this is a membranous glomerulonephritis which resulted in nephrotic syndrome in case 1. You may recall membranous glomerulonephritis and focal segmental glomerulosclerosis are the two main glomerulonephritis which may cause nephrotic syndrome in adults. So it is the frequent cause of nephrotic syndrome in adults. Accumulation of immune complexes is usually confined to the subepithelial zone of glomerular capillaries, and the pattern is a granular one. Immunofluorescence shows granular deposits of IgG outlining the glomerular capillary loops, as we saw in the case scenario. Now, the course of this disease is variable. Possible outcomes include spontaneous remission in 25% of cases. 50% of these patients have persistent proteinuria and partial loss of renal function, whereas 25% rapidly progress to renal failure requiring dialysis or renal transplantation. So this is the uh, possible outcomes or prognosis of membranoproliferative glomerulonephritis. Now here you can see this is the PAS stain of special stain employed to the tissues of renal biopsies. So here you can see there is well demarcated glomerular basement membrane. In the membranous glomerulonephritis, we have thickening of the basement membrane, and that thickening is easily appreciable on this stained slide. Then here in the inlet, you may see the electron microscopic picture. This shows this is the glomerular basement membrane, and these are the epithelial cells. So there is subepithelial deposition of this grayish black electron dense material. These are basically antigen antibody complexes which give this sort of electron dense pattern on electron microscopy. Here you can see in the inlet and the topographic representation, we have again the capillary lumen. Here you can see the RBC in the lumen. Then we have endothelial lining. Then we have basement membrane, and then we have visceral epithelial cell. So the deposition is mostly underneath the visceral epithelial cell. That's why it is called as subepithelial deposit, and it gives this sort of pictures on electron microscopy and on routine histopathology. So the clinical course remains indolent. It's a slow process. Then proteinuria is initially non-selective and does not respond well to corticosteroid. No, as I told you in the scenario, initially the proteinuria remains selective, but ultimately it becomes non-selective. So there is more massive protein loss, and this protein loss does not respond to corticosteroid treatment, because we have certain other disorders which cause nephrotic syndrome and which respond well to corticosteroid. But if the nephrotic syndrome is because of membranous glomerulonephritis, it may not respond to corticosteroid treatment. Progression is associated with increasing sclerosis of glomeruli. As the process proceeds, there is fibrosis within the glomeruli, rising serum creatinine reflecting renal insufficiency and development of hypertension. So this is all the manifestation of sclerosis or fibrosis within the glomeruli. The glomerular circulation is also impaired, and it stimulates the renin-angiotensin system. So this is a renal sort of hypertension. Proteinuria persists in more than 60% of patients. Only about 10% die or progress to renal failure within 10 years. 40% eventually develop renal insufficiency. These are the statistics. Concurrent sclerosis of glomeruli in the renal biopsy at the time of diagnosis is a predictor of poor prognosis. If in the initial biopsy, which comes to the lab, if we see fibrosis in the glomeruli, then the prognosis becomes poorer in this case. So we discussed basically case 1. In case 1, there was a middle-aged man with edema and signs of ascites, okay, although he did not develop at this stage hypertension, because it was the initial stage of nephrotic syndrome. And the patient had selective proteinuria, that is albuminuria. As the disease progresses, it may develop non-selective proteinuria. This patient may not respond to corticosteroid treatment. The renal biopsy shows well demarcated glomerular basement membranes or glomerular capillary loops because of thickening of the basement membrane. The thickening of the basement membrane is because of in situ or circulating immunoglobulins that get deposited in the subepithelial side of the glomerular basement membrane, giving a basically granular pattern on immunofluorescence. Electron microscopy also shows deposition of electron dense material in the subepithelial site. So these patients may develop renal failure, and they may require renal transplant, or they may need dialysis until the transplant. So that was the basically case 1 is a stereotype case of nephrotic syndrome in adults. And remember, again, I am emphasizing this fact, you need to remember the precise definition of nephrotic syndrome. You may not say, okay, there is a protein loss of 3.5 grams per deciliter. No, there is a protein loss of 3.5 grams per day within 24 hours, to be precise, for the definition of nephrotic syndrome. Of course, with proteinuria, hyperlipidemia, and lipiduria. Now, with this baseline case, we may proceed to other primary glomerulopathies, which may result in the clinical syndrome of nephrotic syndrome. This is the case 2. Now, in case 2, you see we have a 30-year-old drug addict which presents with a 6-month history of progressive swelling in ankles and abdomen. Urine analysis shows heavy proteinuria, but no WBCs or RBCs. There is hyperlipidemia and hypoalbuminemia. So it means that all the components of nephrotic syndrome are there. Okay? There is a swelling, edema, then proteinuria, then hyperlipidemia, and although they have not given the precise value of proteinuria, but they have shown that it's a very heavy proteinuria. Heavy means it may be more than 3.5 grams per day. Serum creatinine is normal. There is a renal function, renal insufficiency is not there. ANC is negative, anti-nuclear cytoplasmic antibodies is negative. The patient responds to corticosteroids. Edema and proteinuria recur the following year. Although he gets well with corticosteroid therapy, but after 1 year he again presents with the same episodes, and he was again treated with corticosteroids. On third recurrence of edema and proteinuria, the patient becomes resistant to steroid therapy. A renal biopsy is done and the pictures are shown. So this is a case of drug addict. This is a 6-month progressive swelling and of swelling in ankles and abdomen. So he has a progressive edema. Then he has all the components of the nephrotic syndrome. ANC is negative. It is ruling out the systemic disorders such as SLE for causing renal involvement. This is a negative basically. So negative findings are also important in the scenarios. You see, the patient responds to corticosteroids. So this is a sort of glomerulopathy that initially at least responded to corticosteroid therapy. But with subsequent presentations, the condition becomes resistant to this modality of treatment. The reason lies here in the biopsies. Now here we do not want to make you histopathologist or surgical pathologist, but we show you these photomicrographs just to develop your insight into the disease process and pathogenesis. So here you can see this is a glomerulus, that is a nephron containing this glomerulus. You know that a nephron, a kidney contains millions of these units. So in this glomerulus, you can see there are these pinkish homogeneous granular areas. They basically show sclerosis, fibrosis. Once fibrosis develops in the glomerulus, no treatment can revert this fibrosis. Fibrosis is just like a scar. So post-inflammatory fibrosis develops in the glomeruli, and that's how we have progressive. This process is an indolent one as a progressive one. We have progressive loss of renal function. Ultimately, we have complete renal shutdown and renal failure. But this process takes time and it will culminate in this. So in this scenario, they have done renal biopsies at this stage. Here again, you can see there are certain glomeruli which are spared and there are certain glomeruli which are involved. Okay. So when some glomeruli is spared and some are involved, we employ the term focal. Whereas within a glomerulus, certain areas are sclerosed and certain areas are not. For this, we employ the term segmental. So there is focal, segmental, glomerulosclerosis. You may recall from the previous chart here that focal segmental glomerulosclerosis is one of the major component or the glomerulopathy which causes nephrotic syndrome in adults. Just to recall this table, this is an important table. So here you can see that we have focal segmental glomerulosclerosis. It typically develops in in addicts. Basically, the reason we don't know, but that is an immune sort of process, immune mechanism may be involved, but they develop this sort of lesion. So that was the case. So the case 2 belongs to focal segmental glomerulosclerosis, commonly referred to as FSGS. The previous one we discussed membranous glomerulonephritis, MGS, and this is FSGS. Now, this is characterized by glomerular scarring, sclerosis, or fibrosis. Involvement is focal and segmental. Now you know what is focal and what is segmental. Cause of nephrotic syndrome in 30% of adults. In the chart, it was 35, and 10% of children. It is the most common renal complication of intravenous drug abuse, which happens to be this case. Proteinuria may be so massive as to produce nephrotic syndrome. So these patients may present with nephrotic syndrome, as was this case. In HIV patients, rapidly progressive collapsing form of focal segmental glomerulosclerosis we encounter. So this category of primary glomerulonephritis is also fairly common in HIV patients. Then patients typically progress to end-stage renal disease within 1 year. So it's a very, although it's an indolent, but it's not that indolent. Within 1 year, the major component, the major proportion of both the kidneys may get sclerosed or fibrosed. So these patients would be definitely requiring dialysis and renal transplantation. So that was the second or the first common cause of nephrotic syndrome in adults. Now we have this case 3. What is in this case? Let's see. We may discuss case 3. Now, 6-year-old previously healthy girl has become increasingly lethargic over the past 2 weeks. Now this is basically a child, a girl, a baby girl, 6-year-old. She has become increasingly lethargic over the past 2 weeks. On physical examination, she has puffiness around her eyes. Her temperature is 98 degrees Fahrenheit and BP 100/60 mmHg. Lab shows serum creatinine of 0.7 milligram per deciliter and urea nitrogen of 12 milligrams per deciliter. Normal ranges are there, 7 to 20. So creatinine and urea nitrogen are within normal. Creatinine is up till 1 milligram per deciliter, so they are in the normal ranges. Urine analysis shows pH of 6.5, specific gravity 1.018, 4 plus proteinuria, heavy proteinuria. No blood or glucose. 24-hour urine protein of 3.8 grams. Here again you can see this falls within the definition of nephrotic syndrome, because the patient has signs of rising urea nitrogen, but still within the normal range because of increasing lethargy and so on and so forth. Nausea, vomiting may be there. She has puffiness around her eye, that is edema, and then we have proteinuria. Renal biopsy shows normal glomeruli, no change in the renal glomeruli. Only electron microscopy shows effacement of podocyte foot processes. Podocytes were visceral epithelial cells. They have their foot processes over the glomerular basement membrane. So there is effacement or retraction of podocyte foot processes. This child's condition improves after a course of corticosteroid therapy. So this is one example where we have a glomerulopathy which responds well to corticosteroid therapy. So this is again a case of nephrotic syndrome, but this time this is a case of nephrotic syndrome in a child. And you may recall from that table, here again we may go back to the table, that the commonest cause of nephrotic syndrome in children is the minimal change disease. Okay? Others are less common causes. So what is minimal change disease? We may discuss here. So minimal change disease is called minimal change disease because of this fact in the scenario, that renal biopsy shows normal glomeruli, no abnormality which can be discerned, which can be found on routine histopathology. So that's why it is called as minimal change disease, because this can only be the effacement of podocyte foot processes can only be appreciated on electron microscopy. In adults, proteinuria is generally more selective, albumin greater than globulin, than in the nephrotic syndrome caused by other diseases. Okay. Disease is characterized pathologically by fusion, effacement of visceral epithelial foot processes. Okay. They basically fuse and they open the space between their foot processes. So there is free flow of proteins from the urine and we have protein loss. Visualized only by electron microscopy, that's the name, uh, minimal change disease. Okay. Minimal change glomerulopathy is successfully treated with corticosteroid. Usually, these children respond to corticosteroid treatment and they may get well without any finding of renal failure. So, okay, I will try to speak a bit louder. So I was telling that minimal change disease is called minimal change disease because it gives a normal picture on routine microscopy. So it's on the electron microscopy which when it's get detected. So it's the commonest cause of nephrotic syndrome in children, and the peculiarity about this condition is that it responds well to corticosteroid therapy. While the two previous conditions, focal segmental glomerulosclerosis and membranous glomerulonephritis, they do not respond well to corticosteroid therapy. In the second scenario, we saw that it initially shows a response corticosteroid, but ultimately, as the fibrosis and sclerosis develops, the patient becomes resistant to this treatment. But in children, the picture is different. They respond well to corticosteroid therapy. So this is the topographic representation what happens in minimal change disease. So you may recall from the previous diagrams, we have endothelial cells lining the capillary. This is the capillary lumen, and these endothelial cells have fenestrations. Then we have glomerular basement membrane. It has varying density. The middle part is more dense. So the plasma ultrafiltrate has to pass from these fenestrations within the endothelial cells, then various densities of glomerular basement membrane. Then they encounter this barrier, which is the podocyte or visceral epithelial foot processes. In between these foot processes, there are controlled channels through which this urine comes into this space. This is the urinary space or the Bowman's space. So this is from inside out. So what happens in minimal change disease? We have effacement of these foot processes. These podocytes, they lose their normal contour and they lose their normal function as a barrier. They get distorted, they are effaced, and we have free flow of urine from plasma to the urinary space with lots of loss of proteins and even lipids and so many ions. So this is a free flow of proteins. There is no check. So this is what happens in minimal change disease. So that's why it is called as the minimal change disease. Clinical features: despite massive proteinuria, renal function remains good, and there is commonly no hypertension or hematuria. And so, in contrary to the previous, in adults, it is quite a mild sort of disease process. The proteinuria usually is highly selective, mostly of albumin. Most children, this is important, most children greater than 90% with minimal change disease respond rapidly to corticosteroid therapy. Proteinuria may recur, and some patients may become steroid dependent or resistant. And if they become resistant, then they may be requiring dialysis. Now, case 4. A 38-year-old woman sees her physician because she has been feeling tired and lethargic for several months. So this is a middle-aged woman with a history of fatigue. On physical examination, she is afebrile and her BP is 140 by 90 mmHg. Labs show hemoglobin 10.3 grams per deciliter, hematocrit 30.9, platelets 310,700 per millimeter cube, WBC 5,585. The serum creatinine level is 5.8. Normally it is 1.1. It's quite raised. C3 nephritic factor is present in serum while ANA test is negative. Urine analysis shows 2 plus proteinuria. This case basically is a membranoproliferative glomerulonephritis. So here you can see we have a middle-aged woman. Okay, she is not yet hypertensive. She may develop hypertensive later. Hemoglobin is within the normal range, just slightly lower side of the normal range for females. Hematocrit is low. There is some impediment to erythropoiesis. Platelets are still normal, and WBCs are normal. Creatinine is high. It means renal insufficiency is remarkable. C3 nephritic factor is present in the serum while ANA test is negative. So C3 are the complement component proteins. So whatever disease process is this, it has caused activation of complement, and the C3 nephritic factor is present in the serum. ANA is negative, so it rules out the involvement of kidneys or nephrons in the systemic disorders like SLE. Urine analysis shows 2 plus proteinuria. Renal biopsy shows hypercellular glomerular proton electron dense deposit along the lamina densa of the glomerular basement membrane. So renal biopsy is also showing hypercellularity plus there is thickening of the glomerular basement membrane. So C3 nephritic factor is an immunoglobulin IgG which is formed against the C3 component of the complement system. This is characteristic of this condition. This condition is because of this is a membranoproliferative glomerulonephritis. You may recall again from the table that membranoproliferative glomerulonephritis may cause nephrotic syndrome in adults. Not to the extent to membranous or focal segmental, but it's there. So there is alteration in the glomerular basement membrane, proliferation of glomerular cells, leukocyte infiltration. So there is glomerulonephritis characterized by proliferation, inflammation, and thickening of the basement membrane. Proliferation is predominantly in the mesengium. So here the mesangial cells show proliferation. 10 to 20% cases of nephrotic syndrome in children and young adults. So it's a less component which is occupied by membranoproliferative glomerulonephritis in adults and in children. Secondary MPGPN or maybe idiopathic primary MPGPN. So causes, it could be a secondary process or could be a primary idiopathic cause. So this is another category of primary glomerulopathy which may result in nephrotic syndrome. This is the diagram of membranoproliferative. We have here you can see there is mesangial cell proliferation, because here you can see the staining, that is silver stain, which is again done routinely on renal biopsies. It is showing these staining areas, darkened areas. These darkened areas are because of the dye taken up by mesangial cells. So mesangial cells undergo proliferation here. There is basement membrane thickening with splitting of the basement membrane, because we have deposition of material within the substance of the basement membrane, so it gives the appearance of a splitted basement membrane. Not very remarkable here, but in some capillary loops the expert may see duplication of the basement membrane. Okay. So this is basically because of mesangial proliferation. It is called as membranoproliferative glomerulonephritis. The name has its origin from mesangial cell proliferation. And you may recall that mesangial cells are the cells which are basically residing in the interstitium of the nephron in the glomerulus. Here you can see, as again we know that electron microscopy is done on all renal slides. Here you can see these are the deposits, electron dense deposits of antigen antibody complexes or other electron dense material, maybe proteins, and they cause thickening of the basement membrane. So basement membranes are quite thickened. This is the capillary, and because of this deposition, they may also give the picture of splitting of the basement membrane. Okay. So there are two categories of membranoproliferative glomerulonephritis, type 1 and type 2. So in type 1, we may see the splitting of the basement membrane because of the deposition of these material. Okay. In type 2, again, it may show disruption of the basement membrane because of this electron dense deposition. So whatever the pathology is there, it is basically confined to the membranes, as well as it has basically created mesangial proliferation. So we combine both these terms as mesangial-proliferative glomerulonephritis. You need not to remember these electron microscopy photos, but this is for your understanding of the terminology membranoproliferative glomerulonephritis. Here you can see this is a schematic representation. The antigen antibody complexes or the electron dense material may be deposited within the substance of the basement membrane like this, and in this way it basically reflects splitting of the basement. Although the basement membrane is not splitted, because of this pattern of deposition, we have duplication of the basement membrane on the microscopy. So there is some duplication of the membrane, and here again we have this deposition. So in type 1, there are subendothelial deposits. Here you can see these are the endothelial cells and this is subendothelial. While in the membranous glomerulonephritis, we had subepithelial deposit. You may recall from the previous diagram. So subepithelial deposits, membranous glomerulonephritis. Some endothelial deposit, membranoproliferative glomerulonephritis. Plus, it has another component which is called as the mesangial cell proliferation. Here you can see instead of 2, they have shown 3 mesangial cells. So there is mesangial cell proliferation. The proliferation is also accompanied by activation of these cells. So these cells by themselves elaborate constellation of cytokines, which basically promote inflammation, glomerulonephritis within the glomeruli. So here we have this type 1. In type 2, you may see the deposits are intramembranous. Here you can see these are intramembranous deposits within the substance of the basement membrane. This is the type 2 sort of membranoproliferative glomerulonephritis. So even this membranoproliferative glomerulonephritis has been divided into 2 categories depending upon the morphology of the deposition, the subendothelial and within the substance of the membrane or intramembranous deposition. So this is again a primary glomerulonephritis which has resulted in nephrotic syndrome in this case, in this patient. Then we have this case in the form of an MCQ. So this may help you understand another category of primary glomerulonephritis which may cause nephrotic syndrome. We may do this case. This could be our last case or one or more MCQs. A 25-year-old man has a 5-year history of celiac sprue. So this patient has already a malabsorption syndrome. Several days after a mild upper respiratory tract infection, he begins passing dark brown urine. Dark brown urine means there must be fresh as well as altered blood in the urine. The dark urine persists for the next 3 days and then becomes clear and yellow, only to become red-brown again 1 month later. So the disease, whatever the pathology is, it is showing a remission and relapse. So initially it was dark brown urine, then again after a few days it clears, but again it becomes dark red-brown 1 month later. His physical examination remains unremarkable. Urine analysis shows a pH of 6.5, specific gravity 1.018, 1 plus proteinuria, 3 plus hematuria, and no glucose or ketones. So the pH and specific gravity are within the normal ranges. Protein is somewhat raised. Specific gravity is slightly raised. Protein is somewhat raised. 3 plus hematuria. So he has more pronounced hematuria. And no glucose or ketones. Microscopic examination of urine shows RBCs, no WBCs, casts or crystals. 24-hour urine collection is 200 milligrams. So this protein loss in the urine is less than 3 grams per day. Plus we have hematuria. So this patient must be presented initially at least with the picture of nephrotic syndrome. In nephritic syndrome, we have RBCs, red cells in the blood, in the urine, sorry. We have proteinuria. Proteinuria is typically less than 3.5 gram, as is in this case. And we have no glucose or ketosis, no diabetic ketoacidosis or diabetic nephropathy. A renal biopsy specimen from this patient is most likely to show which of the following alteration: subepithelial electron dense deposits, granular staining of GBM by anti-GBM antibodies, mesangial IgA staining by immunofluorescence, diffuse proliferation and basement membrane thickening, and thrombosis in the capillaries. So these are the options. So subepithelial deposits basically we see in see in membranous glomerulonephritis. You can granular staining of GBM when IgG antibodies we see in good pasture syndrome, in which we have simultaneously hematuria as well as hemoptysis because of the basement membrane involvement of the lungs. Mesangial IgA staining by immunofluorescence. Now, this mesangial IgA staining happens to occur in IgA nephropathy. IgA nephropathy is one category of glomerulonephritis in which the patient gives a previous history of celiac sprue or upper respiratory tract infection few weeks back. Both are basically there in this scenario. Then we have IgG deposition, uh, IgA deposition. And IgA, we are in this patient must have been formed against this upper respiratory tract infection, or it could also be generated. There is a predilection of these patients which are already having celiac sprue to this sort of glomerulonephritis. So the antibodies which are formed against the upper respiratory tract infection, because we know that IgA is a mucosal antibody, it may get deposited, especially in the mesangium, taken and causing this disease process. Diffuse proliferation and basement and thrombosis in the capillaries. Thrombosis in the capillary happens to occur in hemolytic uremic syndrome. Diffuse proliferation in basement membrane thickening we encounter in membranoproliferative glomerulonephritis. So this was a case of basically IgA nephropathy, in which we have this history of celiac sprue, then we have nephritic syndrome. It may proceed on to develop nephrotic syndrome. And then we have IgA deposition, which happens to occur in the mesangium. The less we exclude, because this one, the first one was of membranoproliferative, the second one was of Goodpasture syndrome, the fourth one was the D was of membranoproliferative, and E was of hemolytic uremic syndrome. So the most palatable choice remains is the mesangial IgA staining by immunofluorescence. Of course, you can attempt this MCQ once you know what is IgA nephropathy. And IgA nephropathy, these findings basically are there. So don't get worried. Just study IgA nephropathy. You will be able to attempt this MCQ. There is another MCQ. A 12-year-old boy complains of swelling of his leg for the past 3 weeks. He is otherwise healthy with no known previous illness. Vital signs are normal. Physical examination reveals pitting edema of the lower legs and a swollen abdomen. Urine analysis shows 4 plus protein but no RBCs or WBCs. So edema, urine protein loss of more than 3.5 grams per day. 4 plus means heavy proteinuria. Which of the following are the most likely diagnosis to consider in your evaluation of this patient? Okay, this Hanosch-Schönlein purpura, lupus nephritis, malignant hypertension or renal vein thrombosis, minimal change disease, focal segmental glomerulosclerosis, pyelonephritis, acute tubular necrosis, Wilms tumor, or renal cell carcinoma. So this basically is a child having this condition, and this condition belongs to minimal change disease. You can now well about focal segmental is wrongly written here. So 90% of nephrotic syndrome in children is because of minimal change disease. Focal segmental sclerosis cause of nephrotic syndrome in 10% of children and 30% of adults. So focal segmental is more towards adults. Hanosch-Schönlein purpura and lupus nephritis choice is generally present with nephritic syndrome. They do not present with nephrotic syndrome. So this child has nephrotic syndrome. Wilms tumor E is not a cause of nephrotic syndrome. So the most palatable answer is the minimal change disease of focal segmental. But focal segmental only occurs in 10% of children. So the main choice is the minimal change disease. Focal segmental should be removed from this option. This is wrongly written here. Then is the last case scenario. A 44-year-old man complains of swelling of his legs and puffiness around his eyes. Again, we have edema. His abdomen has become protuberant and feels shortness of breath. This case basically we did in the first scenario. The urine sediment contains many hyaline cards and renal biopsy stained by direct immunofluorescence for IgG shows granular pattern. So these are all the pictures that we saw in case scenario 1, case 1. So this is basically case 1 now, but here we have certain options for MCQs. Which of the following is the most likely diagnosis? Amyloid nephropathy, focal segmental glomerulonephritis sclerosis, membranoproliferative glomerulonephritis type 1, membranous glomerulopathy, and minimal change disease. So we discussed this case in detail. This was our case 1, and the answer is D, membranous glomerulopathy. We started our basically session with this case. So it's now easy to understand. So membranous glomerulopathy is the choice here. Thank you very much for your time and patience. Although the pathologies associated with kidney seem difficult to understand and remember, but these sessions may help you to understand these disease processes. And once you know the basics of these glomerulopathies, you may not find very difficult to attempt questions of nephrotic syndrome or, for instance, nephritic syndrome. So it's all basically based on your understanding of the disease process. Now, two questions. One is why the person is in focal segmental disease becomes resistant to steroid. It becomes resistant to steroids because the glomeruli show sclerosis, fibrosis. Once fibrosis takes place within the glomeruli, so there is no role of anti-inflammatory drugs to subside the inflammation, because the fibrosis, wherever it takes place, even in your wounds, the fibrosis is permanent. So once the fibrosis develops in the glomerulonephritis, nephritis means inflammation, then anti-inflammatory drugs like steroids have no role. So that's why as the disease progresses, as the fibrosis progresses, as the sclerosis progresses, the patient becomes resistant to steroid treatment. Achha, what is the definition of azotemia and uremia? Beta, azotemia is basically a rise in blood urea nitrogen. Simply is that. A rise in blood urea nitrogen is called as azotemia. But in the initial phases, this rise in blood urea nitrogen do not produce any clinical finding. Once they are associated with clinical features like lethargy, nausea, vomiting, stupor, confusion, then it is called as uremia. Okay. Azotemia, only rise in blood urea nitrogen. With clinical manifestations, it is uremia. Basically, it's the degree of the extent of the disease process. Again, there is another question. Nephrotic syndrome. The definition of nephrotic syndrome is very imperative to remember. If you do not remember the definition of nephrotic syndrome, and if the examiner asks you this question and you do not give the correct definition, even if you tell there is proteinuria, protein loss of greater than 3.5 grams per deciliter, then it becomes wrong. So the correct answer is protein loss greater than 3.5 grams per day. So you need to remember the precise definition of nephrotic syndrome. If you miss this definition, the examiner will think you do not know anything about the kidney, the renal system. He may switch over to another topic. For instance, bones, endocrinology, female genital tract, but not the kidneys. So always remember this definitions. Thank you very much.